Hello, everyone. Welcome to the TRT and Hormone Optimization YouTube channel. I'm Danny Boss. I'm joined with my host, Dr. Stephen Devos in Belgium. As for our guest, he's a world-renowned expert who was instrumental in promoting the recognition of traumatic brain injury as a cause of hormonal deficiency and is the owner and medical director of Millennium TBI. A repeat guest on the Joe Rogan podcast. Please welcome Dr. Mark Gordon.
Welcome to this channel. I am Dr. Steven De Vos, the lifting dermatologist, and this is my bro science hunting partner Danny Bossa. If you want to learn more about the most cutting-edge science-based information in the world of hormone optimization, please like and subscribe.
Click the bell button to get notified.
I also invite you to join my other YouTube channel, The Lifting Dermatologist. The link you can find in the description of this video.
Thank you very
How
much.
are you, Mark?
Appreciate it. Doing well. And, far enough away from the fires to, breathe deep and not have too much coughing, but no electricity to run my house. So I'm here at the office today on my day of education.
Oh, wow. So the power's out of the house because of the winds.
Just because of the winds, there's no fire. It's just they're being, quote unquote, precautious, especially when they already have $1 billion lawsuit for having not been precautious up in Paradise, Northern California, 2 years ago that destroyed a whole town.
Oh, geez.
A spark that was blown by the winds.
That's too bad. Shame.
Yeah. But whatever they have to do, they're doing it.
Yeah, exactly. Exactly. The drill. I made a post in the group about who they'd love to see. Your name came up several times. I was familiar with seeing you on Joe Rogan. You've been on there a few times, and I've watched those videos several times. And here you are.
That's boring. But anyway, yeah, he's a wonderful guy. He's wonderful guy. Anyway, the fact that this is being shared with both the medical professionals who practice hormone replacement therapy, as well as the fact that you've got a nice following of consumers that are looking at the area of hormone replacement therapy. The 27 years that I've been working in endocrinology and the 15 years in neuroendocrinology, which is about the hormones in the brain, has led me down a number of educational academic pathways where I look very critical at the way that we have been practicing hormone replacement therapy or hormone replacement medicine or anti-aging medicine, which I call interventional endocrinology from my first book, because the term anti-aging medicine is not very well accepted within the medical community, although it's very clearly accepted in the consumer community as being things that we do to maintain the quality of our youthfulness. And if it's done correctly, that's what'll happen. I mean, I'm almost 67 in January, and I'm still, doing crazy things like an 18-year-old, still think like a 5-year-old, according to some of my 3 daughters or so forth, But in looking at the world of hormone replacement therapy, the most important thing is getting the baseline laboratory testing done correctly and sufficiently. And what I see quite often is that we are only doing a very limited amount of testing, whether or not it's total testosterone or DHT or estradiol levels, and we're failing to do some of the markers that will help us to determine better if the deficiency of the hormones are coming from what we call primary gonadal deficiency, or where the testicles or the ovaries have been burnt out, either from age-related issues, which is mostly trauma, or there's damage to the regulatory system in the brain. And if we would just do 1 or 2 additional tests, we can be much better at understanding the cause for someone being hormone deficient. And for an example, it's if you have someone like I see military, a lot of military who have hormonal deficiencies, and it's not due to the testicles not functioning, and in some cases not due to the pituitary gland not making the luteinizing hormone, which is the signal that goes to both the ovaries and the testicles to say, make hormones. But it could be at a higher level due to something called prolactin. And prolactin, if it's elevated, and it can be elevated for 3 reasons. Obviously, in guys, pregnancy doesn't apply, but pregnancy can cause it to go elevated. But a tumor of the pituitary called a pituitary adenoma, it's a benign process, but it can dysregulate a lot of hormones in our body. And then lastly, trauma. Trauma to the area of the brain called the hypothalamus that's above the pituitary can lead to an excessive production of this hormone prolactin, which shuts off luteinizing hormone. And if you don't have luteinizing hormone, you can't make testosterone. So it would be wrong to put in testosterone in a patient that has prolactin as a cause for hormone deficiency, but better to put something like bromkriptine, an oral tablet, that will stop the prolactin so your luteinizing hormone comes up and you start making your own testosterone. But we fail to do that level of testing. So in every male patient, we do our testosterone parameter, inclusive of luteinizing hormone, follicle stimulating hormone, and also prolactin. Why I added follicle stimulating hormone is because we're starting to see a lot of pituitary adenomas, like gonadotropic adenoma, which is associated with high production of follicle stimulating hormone. So if you do just a little bit more laboratory testing, you'll become either, you'll be recognized as being very good at what you do because you caught something that the majority of healthcare providers who work in this area of hormone replacement don't do. And they don't do it because they excuse it as being, well, you're not going to find it, or it's not common to find it. We're finding it more commonly. And I think it has to do with a lot of the things that we're exposed to: radiation from cell phones, bad air, contaminants in our environment, hormone disrupting chemistry, bad minerals, mercury in our military. We have problems with mercury and with lead from, repetitive gunfire or being exposed to explosives and so forth, which brings up an issue that we see quite a lot. And if you do a comprehensive lab that includes DHEA, dihydroepiandrosterone, and your free testosterone and total testosterone, what will happen is you'll catch people who have high levels of DHEA and low free testosterone. And most people just say, okay, that's the pattern, and ignore it. But if you go back to the history and you ask them about any exposure to heavy metals, it's mercury and lead that can interrupt the hydroxylate that allows for DHEA to convert to testosterone. So you can actually find someone who has heavy metal toxicity by just doing the relationship between DHEA and testosterone. Another issue that we see in prolonged use of testosterone, what happens when you overload the body with testosterone, the body is really smart and it looks for avenues to deal with the overload. And that overload can either go down the estradiol pathway or it can go down the dihydrotestosterone pathway. The estradiol pathway, you call it aromatase, which is estradiol synthetase, which is the enzyme that converts it, which by using zinc can slow down the conversion of testosterone to estradiol. It's a natural aromatase inhibitor, which not only has benefits on blood sugar level, but also on inflammation of the brain, as well as lowering the conversion of testosterone to estradiol. The other pathway, which is very of concern now because of a couple of things that have developed finasteride-related issues that I'll talk about in just a second, is that DHT, dihydrotestosterone, which is the active form of testosterone. It's 4 times more anabolic, and it's 10 times stronger than testosterone in a whole bunch of processes in the body: immunity, wound healing, dropping inflammation, and so forth, as well as giving you peripheral muscle growth. But how you convert the testosterone to dihydrotestosterone is with an enzyme which is called 5-alpha reductase. Now, that 5-alpha reductase is extremely important for that conversion, as well as in 2 other areas that we've totally ignored. One of the most important areas is the conversion of something called progesterone to allopregnanolone in the brain. Allopregnanolone is the chemical that's neuroprotective, neurostimulating, neuroregenerating, and it helps with the synapses of nerves to communicate. That's how one nerve communicates to the next is through this thing called a synapse. So it helps to improve the synapses so you get better cognition, more neuroplasticity, if you will. But what happens over time from using too high of a level of testosterone or just using good levels of testosterone over a prolonged period of time, you burn out those enzymes. And when you burn out those enzymes, you start developing problems in the brain. And it's frequent, what I see is guys who come to us, they'll say, you know, I was with my other doctor and he started me on a testosterone program and I felt great. I was feeling great for about 4 to 6 months. And then I went back to the doc and I said, look, I'm not feeling as good as in the beginning. And the knee-jerk response is the doc just increases the testosterone. And the guy does well for a couple of months. And then again, he starts feeling poorly. And that poorly could be anxiety, agitation, panic attacks, moodiness, depression, suicidal ideation. And why that happens is because you burnt out this 5-alpha reductase, which allows for the conversion of progesterone to allopregnanolone. And he might also have insomnia because this allopregnanolone also stimulates GABA, which is the natural sleeping hormone in the brain. So in April of this year, a new drug was produced and released by the FDA called brexanolone for $34,000 a year. It's to treat depression, anxiety, and postpartum depression. What is it? Allopregnanolone. Where does allopregnanolone come from? Cholesterol to pregnenolone, the mother of all hormones, pregnenolone to progesterone, progesterone to allopregnanolone. So we use $105 a year of pregnenolone, which is unavailable without a prescription and a compounding pharmacy in Canada. DHEA can only be compounded in Canada, not available. You walk into any store in California or in the United States and you buy it for $35 for a 6-month supply, 25 milligrams.
DHEA, from my understanding, is not available in Canada. Like I can't buy it anywhere. I have to get it through Amazon.
I agree with you. That's why I said only through a physician prescription to a compounding pharmacy. You can't find it off the shelf.
Okay.
In Brazil, DHEA is illegal. Just illegal. It's like cocaine, heroin, whatever. It's illegal. In most of the quote-unquote British-speaking countries, Canada, Australia, New Zealand, the UK, you can't get DHEA within the country. You have to bring it in. And it's physician dispensed only. But it's a phenomenal hormone. I'm giving a 2-hour lecture on the 8th of November in Tucson on DHEA and pregnenolone. DHEA, below the neck, protects the heart from ischemic heart disease. And
when you're using, I'm sorry to cut you off. When you're talking DHEA, are you talking an oral? Are you talking a transdermal? Are you talking
oral? I don't use transdermal, generally speaking. What can happen when you use anything like testosterone, DHEA transdermally? There's 5-alpha reductase in the hair follicle. And so when you put, let's say, topical testosterone on the skin, about 70% of it gets converted to dihydrotestosterone, leaving about 30% to get into the system. And for us in treating traumatic brain injury, testosterone is extremely important in functionality in the brain. In the brain, testosterone is responsible for things like sense of well-being, aplomb, assertiveness, competitiveness, memory, recall, the ability to learn new things. Of course, libido we talk about, but estrogen needs to be there too. Things like anti-depression, helps with sleep, helps with an area of the brain called the reticular activating system, helps to keep you calm. Startle responses in guys who develop testosterone, DHT deficiency, they have a high startle response because it turns out that the area of the brain called the limbic system that deals with our emotional interpretation of the world around us, that the side aspects, the amygdala, is sensitive to lack of DHT and testosterone, so you can get startle response. So you can be, hyper with everything. Someone claps their hand and you jumped 3 feet in the air. So in looking at all these hormones, and this is just the tip of the iceberg, they have multi-layers of impact on the system. And whenever we use testosterone, we always supplement in pregnenolone and DHEA. And the reason for that is when you use testosterone, it shuts off luteinizing hormone. Luteinizing hormone is responsible for conversion of cholesterol to pregnenolone, the mother of all hormones. So by using women estradiol, men testosterone, or women testosterone estradiol, what happens is you kill that luteinizing hormone presence in the body and in the brain, and you lose about 35 hormones. So,
just a quick question. When you're adding DHEA and pregnenolone, do you have a kind of a standard starting point that you use in dosing wise?
Yeah, we do, because we do the levels of pregnenolone, because pregnenolone is associated with depression and anxiety. So in the guys coming into us with blast trauma, repetitive gunfire or gunshot wounds or missing limbs or what have you, or missing an eye, you want to check their entire chemistry, hormonal chemistry, their brain chemistry called neurosteroids, the stuff above the neck, as well as the neuroactive steroids below the neck, to know what you're dealing with. I mean, it's about the minute you have all the data or facts in front of you, you can then make intelligent decisions. The more, it's like, I'm seeing a phenomenal picture, a high resolution picture of you and of Stephen, and you're probably seeing a low res of me. But the point is that if we don't have that high resolution of pixels, the data points that make the picture, you get a poor image. And that's what we've been getting with doing suboptimal laboratory testing, is you don't get the, the adequate data for you to make an intellectual or informed decision about how to treat this patient. So we're treating everybody with superficially, not depth. And with all the military, the reason why we have such a high level of positive response in a short period of time is because we do the assessment and we see the pattern, because we've got this incredible data that's come in, and we address it. We respond to the data with our treatment protocols, and that's how they get better. And if you go to any of the websites, or else if you're part of our Sunday Journal Club, you get sent out some of the reports that we generate, as well as our statistics on our population. We've got 2,800 civilians and about 330 military, both inactive veterans, inactive. And we have one doc, Irish doc, who's with the military in UK, who's now in, wonderful, who's now in Vancouver. She's gone through our class, and she'll represent us in as an MD in Canada. Gone through and saw this incredible spectrum of testing and how they're interpreted. Unfortunately, not all our tests available here in the United States are available in Canada or in the UK.
But a lot of the tests in Canada can be subcontracted out. Like if you,
I
remember once I tried to do the estradiol ultra sensitive, and they subcontracted out to LabCorp.
LabCorp in the States.
Yeah.
Yeah. So what we have is we have a conduit where you do all the laboratory work either in Canada or just in the northern states, and it gets sent to our lab in Florida. And the cost of it is, about 1/8 of the usual cost.
Interesting.
Yeah.
Okay. And just anybody can use this service, or
any of our designated physicians. In order to get access to our laboratory panel, which is proprietary, it took us about 12, 13 years to develop this laboratory test. Only docs who have been trained, because if you're not trained in how to interpret it, what happens is you lose the benefits. And which brings up a totally different area. It's that the laboratory gives us suggested ranges, range. And if you go back to the science, you look at how they develop those ranges, it's based on a small sampling population. And that small sampling population, who may not have the same genetic coding as you or me or Stephen, definitely not Stephen's. And what happens is that they're putting my Ashkenazi, East European, Ukrainian extraction under this other form, And that's where the problem is. I don't conform. My body chemistry doesn't conform to, the other people. So what was recommended and what we do is we do the median approach, where if the range is, just taking hypothetical numbers, between 10 and 90, if you take 10 and add it to 90, divide by 2, you get the median of the range, which is 50. So what we try to do is get you up towards that median range. And if need be, less than 100. So we're always within the community of medicine's range. It's only when you get outside that range that they come after you, because now you're treating excessively.
So here's a question for you, because we've interviewed a lot of different types of people with a lot of different types of mentalities. So one of the arguments on the other side of the fence was, say you got somebody inside the clinical range, but they have issues. And now you're bringing them further up. They still have issues. So let's go a little higher. Now you get them significantly past the upper range. Suddenly now everything's great. All my issues are resolved. What happens in that case?
Well, the reason why you had to go up above the into the supraphysiological range is usually because you're doing the one tire approach. And what the one tire approach is, you have a car, 4 tires on it. All 4 tires are flat, and you get to choose one tire to fill up with air. And you think you're going to drive away with a balance. No, there's no balance. It's when you throw in too much testosterone, you lead to a deficit of 35 other hormones, 11 important ones in the brain, and that's why the patient doesn't perceive they're getting better. So what you need to do is, when you give testosterone, you need to give pregnenolone and DHEA as a minimum. And then people who are on injectable growth hormone, what happens with growth hormone, it is, in all my lectures that I give on growth hormone, it is the key cardinal hormone in the body. It regulates vitamin D, testosterone, thyroid, conversion of thyroid. Everything is regulated by growth hormone, the 9 proteins that it stimulates to be produced in the liver. 75% of the chemistry that is generated by growth hormone comes out of the liver. So the liver should be called the endocrine gland, technically. Things like IGF-1, IGF-2, binding protein 1 through 6, acid labile subunit. These are all extremely important in functionality of growth hormone, which regulates blood sugar. When you're on growth hormone, you can get a drop in blood sugar. So if you don't understand the science behind it, you think the person's just not eating, or they're hypoglycemic because it's just, genetics or whatever. But it's due to the side effect of growth hormone stimulating IGF-1, which has a 10% crossover to insulin. That's why they call it insulin-like growth factor. Okay? And, so we have to be more understanding of the tools that we use. We have to embellish our skills. And that's what I do. That is my plight. That is my role as an educator, is to share these things so that the treating physician becomes better at what they're doing and offers the patient another level of quality. It's like, I've been going to the male clinics and asking them to take a look at our training program for traumatic brain injury. If they're already doing HRT for 5 years, they're proficient. But we give them another layer so they can expand their population to causality. The majority of the people that we see with hormone deficiency is not because they woke up and were 60 years of age or 70 years of age. Throughout their life, they've been exposed to traumas that we totally ignore. Totally ignore. Do you remember how many times you fell and hit your head between the ages of 3 months of age and 1 year when you were learning how to walk? Nope. How about between 5 and 10 when you were learning how to roller skate, skateboard, or ride a bicycle? How many times did you hit your head? Or how many times did your parents, while driving you around, have a sudden stop? No accident. They just stopped short and your head went forward and back, and you developed a counter-coup trauma to the frontal and occipital parts of the brain, which altered your cognition, your memory, your judgment. This is what we see in these guys who have blast trauma, which damages the frontal lobe, or the guys who, were, blown up and came down, like my partner, Green Beret partner, was up in the air and came down. He was unconscious for 5 seconds maybe, but 3 months later, he's on 13 medications and a full-blown alcoholic. And then he gets on treatment. He's off everything. 2 years later, writes a book, which becomes Quiet Explosion, a movie, a documentary by a Hollywood producer. And he's graduating from Pepperdine with a master's degree in business administration. So, and we have a lot of guys graduated MIT, Harvard, Ranger, Army Rangers. But it's about understanding the benefits of doing everything in balance.
When you're talking about the sorry,
go ahead.
When you're talking about the ranges, so I guess the argument I can make, and I guess others have made, will be, if we're just going to use testosterone as an example, back in 2006, the upper end of normal in NGDL was like 1596, if I'm not mistaken.
Yeah.
And then it went down to 1500 and 40, and now we're down into like the 800s.
Yeah.
So if you're saying want to get somebody, somewhere in the middle of the ground, if that range is an ever continually dropping range, if you got somebody dialed in, 5 years ago, but now the range is here, what happens? You say, okay, we got to lower your dose. You're too high. Like, how does that?
No.
How does that work?
No. What you do is, as a physician, what you do is you write down, in your chart, you acknowledge the fact that the ranges have been dropping, but the beneficial effects of the patient. Here's an example. It says for this antidepressant medication, the optimal dose is 150 milligrams, but the patient needs 300 milligrams. Is the psychiatrist going to get in trouble because he does no objective laboratory testing to determine the necessity of the drug he uses? No. Is he going to get in trouble because he's using twice the normal amount? No. Why? Because based upon his clinical acumen and that patient, and he writes it out, that even though the recommended dose is blah, 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 the patient doesn't respond. That's the genetic uniqueness of each and every one of us, as well as the possibility that the reason why he is not responding to lower doses because there are other hormones you've missed.
We do see a lot of doctors getting in trouble for that, though. Like my own doctor got in trouble, and I'm going to have him on a webcast soon. But he got in trouble for allowing, I believe it was thyroid, allowing his patient to play with their thyroid dose per day to figure out what is the optimal dose for them. So here's the maximum you can take. Start here, work your way up slowly to find where you feel good. And that was reported by a pharmacy. It went to the board. Blah blah blah. Meanwhile, 9 months suspension.
Yeah.
But in his, like you're saying, he says, well, this is my, this was what I established to be a max dose. I knew that she would need more than this, and I let her figure out where it was.
Yeah, you need to write that down. And this is all about medical documentation. This is, the function I play for the Medical Board of California as a consultant is to adjudicate or to look at the documentation to make sure they've CYA, they've covered their asses in what they're doing. As long as you document it, you can then have an argument that, okay, at this dose, the patient failed to get the benefits, okay? Thyroid medication has the highest amount of documented articles on relationship of suicide. It's like 435,000 articles written about thyroid deficiency and suicide, when there's about 97,000 on testosterone. Growth hormone has about 18,000 articles, and pregnenolone has a lot more. The use of pregnenolone, or pregnenolone, progesterone, allopregnanolone, has now been validated and vindicated because of this new drug that came out, brexanolone. The fact that the metabolite of pregnenolone, brexanolone, is $34,000 a year. A vial is $7,680 or so per vial, and it averages $34,000 a year is what you need. And it's an injection. It's an IV injection. And all you need to do is check their pregnenolone level and raise it. And $105 a year pregnenolone. Life extension. Okay? It works phenomenally well. Okay.
This would be oral as well, correct?
So, yeah, and it's all oral. You want to get first pass through the liver, get sulfonated. You have to activate it, sulfa, but you want it to get into the brain. So one of the important things that you've just opened up is what hormone testing we use to validate testosterone. And it's usually total testosterone, right? What is total testosterone?
It would be all of the, I've always been taught that the free testosterone would be the one you really want to look at, and total is kind of somewhat irrelevant. But
well, total testosterone's junk.
Right.
And we've been using the Holy Grail to dictate whether or not a patient should be put on testosterone, and how much testosterone to be given is based upon this mythology of total testosterone. 2% of it is bioavailable. We have a case that went through many VA doctors, private doctors, who refused to give this individual testosterone replacement because his total testosterone was 853. The free testosterone was 4.5. And
which in that case you would have to raise.
He had all the symptoms of hypogonadism. So the doctors look at it and says, well, his free total testosterone is 853. He should be doing well. If he's not doing well, it's because he's depressed. And they totally negate the free testosterone. Okay? So if you have a total testosterone of 853, what is the predicted level of free testosterone you should have?
On 853, you'll probably wind up with somewhere around 10-ish NGDL, perhaps.
Use the 2% rule. Use the 2% rule. So 2% of 850 is 17, and he's got 5, we'll say. So where's the other 12? What happened to the other 12?
You're going to explain it to us.
Well, it gets converted to other things. Due to selenium deficiency, it can be converted, regardless of 5-alpha reductase, to DHT. It can be bound to sex hormone binding globulin. It can become epitestosterone. It can become estradiol. It can go to androstenedione. It can go through all these different pathways to become other than what you need, which is free testosterone. The unique character of free testosterone is it passively diffuses into the brain. Dihydrotestosterone needs to be actively transported, therefore it's limited. It can't get into the brain. But DHT is extremely important in the brain because it's 10 times stronger than testosterone. And testosterone gets converted to DHT in the brain. We know this as a fact because when we look at people who have, and I apologize for the terminology used out there in the muscle building world, called DECA-DIC, which is people who are on nandrolone decoinate or on Anavar or on Winstrol, which are DHT congeners. They look like and function like DHT, but they can't get in the brain. And if you don't add a little bit of injectable testosterone to it, you wipe out your production of luteinizing hormone. So you can't make pregnenolone to go to DHEA, to go to testosterone. So you wipe out your free testosterone level, and all you have is this DHT in the blood, but not in the brain. And that's why you get all the symptomatology associated with this thing called DECA-DIC or nandrolone decoinate syndrome. So you need to have free testosterone to get into the brain to do its functioning, okay? Otherwise, you have all the symptomatology that is of a deficiency. And this.
Would you say there's a? I'm so sorry. Go ahead.
Go ahead.
Would you say there's a kind of an ideal target range of free T? There are some people that we've spoken to that say,
go look at the laboratory's ranges. That's it. The guy who had 4.5, the range, the median of the range is 15.3. So regardless of what the total testosterone is, we bring the free testosterone up to the median or higher. And then the question is, okay, what do you do about this disproportionate conversion of free testosterone to total testosterone? What do you do about it? What's the cause for the conversion? And the reason for the conversion that we started seeing about 3 years ago and started treating a year and a half ago is with trace minerals. You look at the zinc. Zinc lowers the production of estradiol. Selenium lowers the production of dihydrotestosterone. How do you lower sex hormone binding globulin? Everybody thinks sex hormone binding globulin is a bad thing. It's not. Sex hormone binding globulin has a secondary receptor on the cell that works just like the androgen testosterone receptor or the androgen estradiol receptor on the cell membrane that does the nuclear, the transcriptional impact on DNA. So it's a STAT receptor, it's another receptor, but it's with sex hormone binding globulin attached to testosterone or estradiol. So sex hormone binding globulin is not a bad thing. We've given it a bad name because we say, oh, it steals free testosterone. Well, it steals it and does something else. Now, if you want to get rid of this sex hormone binding globulin, how do you do it? What stimulates sex hormone binding globulin to go up? What stimulates sex hormone binding globulin to go down? Free testosterone drops it. Dihydrotestosterone and estradiol raises it. So in our office, 45 is the median of the range for sex hormone binding globulin. When it's less than 45, it means that you've got a predominance of free testosterone, regardless of what the number is. You don't look at the absolute number, you look at the fact of it being a net effect. Free testosterone, dihydrotestosterone, sex hormone binding globulin, or estradiol, it's the net effect on the liver's production of sex hormone binding globulin. So DHT and estradiol causes it to go up. So if it's greater than 45, it means you're more in the DHT estradiol dominance. So how do you reverse that? Well, you have to make sure you have adequate amount of free testosterone.
Would you ever do anything to, something that we see a lot in the European countries, because they're very much tied to physicians saying we cannot give anything beyond a certain dose. And if they have guys that have high SHBG that are still symptomatic, all the symptoms of hypogonadism, instead of raising the dose, which they're not allowed to do because they've hit the max dose, what they'll do is they'll start giving things to lower SHBG to free up free T. I think it's silly. What are your thoughts on that?
I think it's silly because what you do is you stop the two things that cause sex hormone binding globulin to go up. You lower the production of estradiol by using zinc citrate, 60 milligrams to 120 milligrams a day, broken up. If you take too much at one time, it causes nausea. Also, making sure your selenium levels are great. Selenium, organoselenium, or just giving selenium citrate or selenium fumarate or whatever it is. Selenium also works very well on the thyroid to lower the amount of reverse T3. In a lot of countries, you know, I had to write a paper to defend one of our docs in Auckland, New Zealand. I think it's Auckland. She did an unusual thing for the medical community she was in. She did more than just a TSH level. She did a free T3, free T4, and reverse T3 level, and found the reason why the woman was not responding well to her thyroid was because her supplementation with T4 Synthroid was being rapidly converted to T3. And what causes a reverse T3, which is non-functional and blocks the receptors for functional T3. So how you improve that is you look at B12, folic acid, iron, ferritin, selenium, and iodine. And you hope she doesn't have, you know, Graves' disease or Hashimoto's thyroiditis, which can also increase the production of reverse T3, as well as can cortisol. Elevated levels of cortisol will interrupt the normal production of T4, T3, and give you reverse T3, which is inactive and blocks receptors that could be used by functional T3. So selenium is very important. And that's basically, you know, the key. So we see people who have high sex hormone binding globulin, and they're at, for us, what I'd like to call the maximum of supplementation with hormones. And then what we do is we give them trace minerals. And then we monitor them, and we see that their production of the DHT goes down. If DHT goes down, sex hormone binding globulin goes down. If estradiol goes down because of zinc citrate, then you get a reduction in sex hormone binding globulin too. Or if you increase the free testosterone, and you increase the free testosterone not by giving any topical products, by an injection, or what we've been using quite a bit of is clomiphene citrate. Clomiphene citrate should be the first product used on any male less than 40 to stimulate their production of testosterone. Now we have over 600 people in a study that started in 2014. And in fact, I had 6 head traumas, was growth hormone, testosterone, thyroid deficient back in the 90s. And that was the cause for me being on antidepressants, obese, and not very happy person. And within 3 months of being on a protocol to replenish everything, my life turned around. And that was the basement for, where I'm at today. In 97, went through that. And then in 2004, in preparation for a lecture for an organization, looked at the neuropsychopharmacology of hormones and saw these articles. My epiphany article that you probably saw in one of the lectures I gave was from Turkey, where pugilists in Turkey had a very high occurrence of growth hormone deficiency. In the brain, growth hormone is important for maintaining the conduit for neurotransmitters they call microtubules, also adjusting inflammation in the brain, repair, keeping the stem cells in the brain, called oligodendrocytic precursor stem cells in the brain, active, so it can help repair the brain. And T3 is a very important component of that process of maintaining healthy stem cells in the brain, and the hormones for doing that.
Do you ever feel a need to, you were talking about estrogen, do you feel a need of keeping it in a certain range? Do you let it just balance its thing with testosterone?
Nope. I stopped chasing it a long time ago. About a year ago, the AMMG, which is the primary organization that I lecture within, Age Management Medical Group out of Florida, it got to a point where physicians and consumers, male consumers, were getting a little bit hyper about estrogen. And we know from studies out of Harvard by one of my buddies or one of my colleagues, Abraham Morgenthaler, who wrote the book Testosterone for Life, that refutes this whole fantasy mythology of testosterone causing prostate cancer. He talks about how important estradiol is in male physiology. And we know it by looking at female physiology, how important it is in males. Estradiol increases growth hormone production in the brain. Estradiol increases blood flow in the brain through nitric oxide and through the enzyme endothionitric oxide synthetase. And it helps with protecting the heart, the lining of the arteries, blood vessels, the bones, and so forth. And it helps growth hormone in the liver generate those 9 proteins that are stimulated by what we thought was growth hormone alone. Estradiol and growth hormone help. So I've never used an Arimidex or an anastrozole or a estrogen blocker per se, because you lose all these benefits that I just went over when you start using it. And the reason why most people need an aromatase inhibitor is because you've overdosed them on testosterone.
What about the effects of zinc acting as a mild NTE? Are we not doing something to bring it down regardless?
Yeah, I use zinc as the go-to product in everyone because of the benefit in the brain as it drops inflammation. Zinc is used in superoxide desmutase, is an important enzyme in the brain that helps to regenerate antioxidants like glutathione-related products in the brain. And they're all based on like zinc, magnesium, manganese, and you have to make sure you have the enzyme there and the mineral. So zinc's very important for that. So that's again, the levels are very, very deep. And, I work from a molecular level, a cellular metabolism level at the molecular level. So on how to regulate cellular functions. So our latest, I've also have a pharmacist license. We develop products that are very, very unique. And one of the first products was our growth hormone secretagogue, which is available in Canada, secretropin. We got one of those NPNs, NPRs, NP, whatever, through a doctor who pushed it through. But it's been a battle in Canada. Even though we got the NPR or NPN, they just keep on fighting about the products.
But in the United States, kind of in the way of like something like everyone's heard of that MK677. Is it kind of like a similar mechanism?
That's SmithKline. I'm going to be giving a lecture on secretagogues on the 8th at 7 o'clock in the morning, I think it is. And secretagogues, either the GRP6s, the cimarellins, the MK477 or 744, whatever the number, 677, they're 8, 9, 10, and 11, 12. And, all these peptides coming out now, all these brain peptides, they're all based upon a splicing of the growth hormone releasing hormone. It's 44 amino acids, or 46, 44, I think it is, and they use 23 to be cimarellin. But using a one pathway, what happens is you burn it out. And there's a process that they call homologous downregulation, where from using a product that only hits one avenue, after a while, you either need to increase the dosing or else it stops working. And with the product secretropin or dinotropin, they approach 5 different pathways. 5 different pathways. So you don't burn one out. And, we're finding that whoever designed us relative to growth hormone knew how important growth hormone would be. There are amino acids that stimulate growth hormone production, like lysine, alpha-ketoglutarate, and an amino acid that stops the destruction or the loss of growth hormone production, like arginine. And then things like dopamine stimulate more growth hormone release through the DR2, a dopaminergic 2 receptors, and you can use natural products like mucuna purins, which is in the product. So we have a product that addresses the brain's ability to augment, upregulate growth hormone production at night. So we've seen 20% to 650% increases in growth hormone production in short period of time. I just had a vet on yesterday, today's Wednesday, Tuesday, 30% increase in 1 month of his growth hormone level.
Would you say that for people, would it be kind of maybe not recommended or inadvisable to use peptides, and instead to either use a GH secretagogue or just find levels to increase GH in other ways?
Yeah, there's no harm. I look at things of what's the most cost-effective, efficient, and easy to use. Cimarellin, you have to inject it, and the other peptides you have to inject. And there's a legal issue to it. You got to get a physician to prescribe it. If it's not a peptide allowed, then you just got to go and get it and know what you're doing, read the literature. With the secretagogue, it's 100% natural products in it, and it's oral, and it gets absorbed because it's a nanoliposomal product. But that was the first one, and secretropin went into physician-only hands in 2006. And it's only been dispensed by physicians since 2006. And why are physicians dispensing it? They're testing it, and what are they seeing? It works. So, that's hands down on that. Second product that came out was called CME, Clear Mind and Energy, because a lot of the vets we were seeing with blast trauma were having problems with energy production. If you look at the literature out there and what they call a meta-analysis, you take a lot of articles. I think it was like 44 journal articles looked at fatigue in blast trauma. It was the #1 symptom. And that's because when you have blast trauma, you lose a chemical that's produced by the hypothalamus called orexin, which is the stimulant of the body. And if you lose this orexin, the severe form of it, you get narcolepsy, which is sleeping. You're standing and then you're just sleeping, narcolepsy. And that's due to this orexin A and B. Okay, and blast trauma, inflammation in the brain, which is the premise by which I work with people with traumas of all forms, not just military. My daughter takes care of all the civilians, from all the football players, the NFL, the NBA, the hockey players, the Russian hockey players that we see. And the inflammation that was created in the brain changes the chemistry, so you can't make the brain hormones or regulate the hormones through the pituitary to the glands below the neck. And also the immune system is stimulated by testosterone, which is, I was on Joe's Rogan's program, and I made a comment about testosterone. We only look at testosterone on one level, the reproductive, the sexual aspects to it, the gender-related issue, but it has a totally different additional benefit. It increases the anti-inflammatory cytokines chemistry of the body that drops inflammation, while it drops the inflammatory cytokines. The Th1s are inflammatory, Th2s are anti-inflammatory, and then it stimulates the immune system to generate CD4 and CD8 cells, which defend us against attack, viral, bacterial, cancers. So I said this on Joe's show, and I get this email from this doc who's basically telling me I'm the biggest liar on the planet. So I love getting those emails. I love challenges, because my library of these specific articles is about 8,400 articles. So I sent them a packet of 30, 40 articles that just addressed the alternate benefits of testosterone in the body, the secondary layers that we just haven't taken advantage of using. Our patients, every month, they fill out something called a monthly program questionnaire, which they subjectively answer 25 questions. And one of the questions is, have your allergies improved or worsened or stayed the same? The next line is, have your occurrences of colds decreased, increased, or stayed the same? And what happens within 6 to 9 months on our program, their allergies improve and their frequency of colds and the intensity of colds diminishes or is gone. And that's the beneficial effects of things like DHEA, DHEAS, testosterone, dihydrotestosterone on the immune system, stimulating the immune system. We have a patient that flies in from Stockholm, Sweden, mild to moderate Parkinson's on 3 medications. And in 90 days, she was 70% better. And her doctor in Sweden, she stopped her medication. And because Parkinson's is an inflammatory process, it's in the literature, period. I mean, you go to Google Scholar and put in, Parkinson's plus neuroinflammation, brain inflammation. And who gets Parkinson's? We call it boxer's dementia, or boxers, they get the palsy. That's all Parkinson's. And it turns out that the dopamine that is lost from chronic head trauma, that can be upregulated with testosterone. Testosterone also improves the recognition of dopamine at the receptor. And at not only the area of the brain that we focus on called substantia nigra, there are other areas in the brain that produce dopamine that if you can get them all to increase dopamine, their cumulative production stops the Parkinson's, which are, the pill rolling and the stooped and the flat faces and the shuffling gait. The stuff we see with Michael Fox, that we saw with Michael J. Fox, was the medication he was taking called tardive dyskinesia, causing that jerkiness. That's the medication. So
it's a medication
that's medication called tardive dyskinesia, which is from medication. And there are antidepressant medications, antipsychotic medications, a lot of medications that can cause that. So what I advise anybody who comes in here who's on a multitude of medication, I don't stop their medication. I don't stop it. I say, go back to your doctor and you figure it out with them. And they start looking at the medication. They see the side effects that they never looked at. Statin drugs for lowering cholesterol, another mythology, is associated with irreversible diabetes. Statin drugs wipe out all your hormones. Vitamin D, CoQ10. It's documented. But
crazy. It's still being, I speak to people every day. I'm on statins, and is my TRT going to interfere? I'm like, why are you on statins?
Yeah.
And it's just, people haven't caught up. It's odd.
Well,
where do you see, do you see, have any ideas as to where you see kind of this whole area of, hormone optimization, TRT, whatever, evolving? Do you see other things down the road coming in to
Yeah.
improve treatments even further? Do you see maybe growth hormone becoming more and more widely accepted in protocols, or other compounds? Or
I think it's a great question, and the best answer I can give is that HRT is lifeline. You know, it's like that program, whatever that program is, where they talk about a lifeline. Correctly done, hormone replacement therapy will enhance, improve the quality of life. And if our goal in longevity is just to have years, that's not the key. It's about quality of life over a prolonged period of time. And HRT is a key. A doctor, I was at USC, and a doc at USC, Caleb Finch, wrote a paper which was called The Neuroendocrine Theory of Aging. Beautiful thesis, phenomenal reading. And what he basically stated was, if we allow our hormones to drop, it'll lead to our accelerated death. Okay? And I see that. I see that quite a lot. And the literature is now, in the key literature is starting to talk about it. In women who have menopause, and their levels of LH, luteinizing hormone, and follicle stimulating hormone go up, and their levels of testosterone, estradiol, and progesterone go down, the literature is now talking about they being more prone to cognitive impairment, dementia, Alzheimer's, Parkinson's, all rolled into one. Why? Because each one of the hormones has another factor of anti-inflammation. Estradiol, pregnenolone, progesterone, allopregnanolone, pregnenolone sulfate, testosterone, all these things have anti-inflammatory benefits that we're now just starting to look at, or just starting to see in the research. And it's not one article, it's hundreds of articles. The only problem is we're not reading. And if we start reading, as opposed to relying on a third party to tell us what we should be doing in our medical practices, take more responsibility and concern for what we're learning and what we're being told, checking it, testing it to see if what we're being told is really valid or just valid for the sale of something. I think that's important. So where HRT is destined to go is, as more doctors become better qualified to practice HRT because the information is readily available, you're going to see people having higher quality of life. And with that higher quality of life, they'll need less medication to treat illnesses because they won't be ill. Study that was done on vitamin D. You know how many articles are written about vitamin D and the heart, protecting the heart? If you were to guess, how many articles?
I have no idea.
1.9 million.
Jeez.
How about articles about vitamin D and neuroinflammation, inflammation in the brain, and helping to quell it? 37,400. There are 2.14 million articles on general inflammation throughout the body and vitamin D. There are 304,000 articles about autoimmune diseases and the benefit of vitamin D. We're talking about Hashimoto's thyroiditis. We're talking about rheumatoid, lupus. We're talking about Crohn's, ileitis. We're talking about inflammatory diseases. The literature is teeming with it, but no one's reading it.
And we're learning more and more that virtually all diseases becoming due to inflammation.
And the information needs to be consolidated and delivered. And this is what I do for 8 hours, 16 hours, 2 8-hour days back to back, nonstop lecturing. And one of the new lectures that I've incorporated is with a Dr. Lee from Clinical Peptide Society out of Orlando, who's going to be talking about the neuropeptides, the brain peptides, and what you can do to improve cognition. And if you've had traumatic brain injury or post-concussional syndrome, or you have any one of the labeled psychiatric diseases that now, as of November 2017, a beautiful article came out associating all the psychiatric illnesses like schizophrenia, depression, bipolar, obsessive compulsive anxiety, PTSD, if you will, post-concussion trauma, CTE, Alzheimer's, Parkinson's, MS, and ALS, all with inflammation. And that's how this lady who flew in from Sweden was able to get the improvement she did because it's being supported. We were doing it in the past, but now we have this literature. So the peptides peptides are important. Had a discussion with a researcher with TB500 and BPC157. And the two of them together for helping repair rotator cuff tears, 3 tears, partial tears, not complete through and through, repairing it in 2 weeks. Getting repair in 2 weeks, where he was offered surgery by his orthopedic surgeon. And he said, hold on, I'm going to try this protocol first. Tried the protocol, went back to his orthopod, and he's got, full range of motion on his left arm. And the doc say, what are you doing? Teaching him, you can do PRP, So one of my daughters does PRP and hair, scalp, skin, bones, whatever, on PRP.
Okay. Stephen kind of left you out a little bit on this video. Do you have any questions for Dr. Gordon?
No, I was just wondering, are you treating any patients? Because I heard you talk about the importance of growth hormone with injections of low-dose growth hormone for anti-aging benefits?
Well, the use of growth hormone, technically in the United States, we cannot use it for anti-aging. We need to find that they have adult growth hormone deficiency, which we see, 1 in 100, maybe 1 in 70 that has hormone deficiency. So we do use it. And the responses are very impressive. A lot of the guys that we're treating with it at present are between the ages of 25 and 52, who are all veterans, who all had blast trauma, and it interrupts the pituitary. And so what they see from the use of growth hormone, and I'll basically state it based on an article that was published, they found in people who have a form of depression called treatment-resistant depression, where they've been put onto a multitude of antidepressants and they don't work. They're still depressed. And so they're put on so much medication that they're unconscious or semi-conscious, drooling, but they are not depressed. They're not suicidal because they have no sensation. Well, what they found in 61% of these people with treatment-resistant or atypical depression was growth hormone deficiency. Within 1 to 2 months of replenishing the growth hormone, they had improvement in their depression, and they ended up with 4 benefits. They slept better. They had more cognitive ability. They had better interpersonal relationships, and they were less reactive to things that were going on around them. They weren't hyper. They were calmer. So yes, we do use growth hormone, and back before there was all the restrictions on growth hormone, back when I was using it in the 90s and up until 2007, the response on it was phenomenal. There are articles in the Alzheimer literature talking about the benefits of the growth hormone on the microtubules. And, in Alzheimer's disease, because of the beta amyloid, the protein that creates it, it destroys the conduit for neurotransmitters to go down, specifically acetylcholine. And so what happens is these microtubules are disrupted. They found growth hormone restructures them, rebuilds them. Okay? And I did a study.
I'm so sorry. There's a little slight delay between us, so sorry if it sounds like I'm cutting you off. Would you say that there's like a minimum dose of growth hormone that accomplishes this typically, or is it?
Well, I hate saying there are standard approaches because you need to look at the patient. Each patient is so different. So what I usually start off with is a half a unit twice a day. Okay? It turns out that in the morning, growth hormone has a little bit more muscular benefit. And at nighttime, if you look at some of the literature that would talked about nighttime, when growth hormone is normally produced 8 at night to 4 in the morning, that's when we get mobilization of our body fat to fuel our brain when we're sleeping, or fuel the body when we're sleeping. The body cannibalizes the structural fat. So if you take it at night, you can actually lose your fat a little better. When you looked at people who had growth hormone deficiency, they were obese. They developed obesity because they didn't have the availability. But half a unit twice a day, And if they need the nighttime dose because they want to lose body fat. And if it's an orthopedic problem, I've had some high-end military with orthopedic multiple breaks that we put them onto a protocol, and they accelerated in healing and stayed in the forces where they were being looked at as being kicked out. An article that came out talking about physical rehab in the military in guys who had low, normal, and high levels of testosterone naturally. They found that the people with the highest level of testosterone rehabilitated faster from their orthopedic injury, post-surgical or non-surgical orthopedic injuries, much faster, got out of the hospital sooner. They accelerated in their rehab protocol and therefore were out of the hospital faster with testosterone. So growth hormone and testosterone together are key. And then you need to support them with the DHEA, 25 milligrams a night. Why at night DHEA? Because DHEA will increase growth hormone production by up to 20% if taken at night. Melatonin, I take it. I don't need anything to help me sleep. Melatonin increases growth hormone at night. Vitamin D increases growth hormone at night. Estradiol increases growth hormone. Testosterone increases growth hormone. So we've got a lot of things that we're taking that we don't even understand that they also help in other areas. So I don't jump into correcting people's growth hormone level. Yes, I do use the secretagogue firsthand. It's cost effective, simple to use, and I have no legal hurdles to go over. I don't have to do challenge tests. I don't have to, write 15-page reports. And the response is very good.
Awesome.
You have time for another question?
Yeah.
Since you're the specialist on hormone optimization and brain chemistry on melatonin, what's your take on dosage and the benefits for anti-aging, anti-cancer properties, antioxidative?
Yeah.
What are you taking it for or giving it for?
Yeah. Great question, Stephen. Let's see. What's Russell's last name? I'll have to look it up and send it to you. The guru in melatonin application theory is in Texas. Russell Reed. No, I'll get to his last name.
I'm Googling it.
He's in Texas. Russell, I got on my computer, but I don't want to interrupt our conversation. But he takes some outrageous 50 milligrams to 100 milligrams a day. He is crystal clear, and he's 86 or something years of age, crystal clear, cancer-free, the benefit of melatonin, anti-free radicals, and as we know, oxidative load, oxidative stress, free radicals are what causes cancer and all our illnesses. It helps with sleep. Melatonin helps with sleep. It's anti-cancer, so I'm just repeating myself, but it has incredible benefits. I, unfortunately, have to be very careful with it. I can take 1 milligram. Well, you got Russell's name?
I got two of them, and they're both talking about melatonin. So one of them is a Russell Foster.
No.
And another one is a Russell J. Reader.
That's right, Russell Ryder.
There you go.
He's the guru, Russell Ryder. He's the guru. Yeah, we were in Mexico. We opened up Mexico about 10, 15 years ago for another organization. That's when we met. And he liked us because we're all getting drunk on tequila and scotch. So I said, the best fun he ever had. Anyway, so yeah, and at that time, my beloved buddy, John Chrysler, was there. Yeah. So
That we
anyway,
all know passed away at the beginning of the year.
Say again?
That we all know passed away not all that long ago.
So we have, in 2020, we have a fund that will be starting, which is in his honor. And John and I worked together over the years. Great guy. Anyway, so yeah, melatonin, phenomenal. I think everybody should have it. Even though they don't need anything to sleep, they should have it. With me, 1 milligram is good. If I take 1.5 milligrams, I wake up groggy the next morning. And that's because I take 100 milligrams of pregnenolone every night. Pregnenolone and melatonin together are additive, and I'm crashed out because GABA. Pregnenolone augments GABA production and then melatonin. And the
I'd love
benefit-
to take this stuff, but the slightest bit of pregnenolone in my body makes my little friend downstairs decide he wants to go on vacation. And I've tried it in many different ways and many different methods of application.
That's a real rarity. So it's the progesterone. It's getting blocked in progesterone. And the only reason why progesterone gets blocked or backed up is because you've lost 5-alpha reductase, which could be from prolonged use of testosterone. So what I'm looking at is how to correct that. That's the study that we're working, academic study that we're working on now, is to find what we can give a person to return the 5-alpha reductase 1 and 2 back to normal levels.
Awesome.
Okay.
It was amazing to have you here. I don't want to take up too much more of your time. It's already been a little bit more than an hour. You'd promised me an hour, so I don't want to take advantage.
Okay.
Yeah. I hope to have you back at one point. It'd be great.
Good.
Thank you so much for coming
Thanks.
on. Anything you want to add? How do
the only thing I want to add,
your,
if anybody wants to learn about what we do with the military, we're always looking for doctors, regardless of where you are. We're working now. One of the emails was a notification that project that we have with the British government has come to fruition, to help their military, to help educate their doctors, or to expose their doctors to the science that we have, or the results that we have. That is at our new website, which is TBIHelp, HELP now.org. And it has the programs that we have, doctors who we've trained throughout the United States. We have one key naturopathic doctor in Vancouver who is doing a great job. He's listed on our website as presently the only international doc in Canada. We've trained docs in Southeast Asia. I have projects in Thailand for 14 years, Vietnam for 2 years, and Cambodia for 2 years, China on and off for 10 years, Canada, lectured at the UOT, University of Toronto, for the Department of Physiatry, Physical Rehab Medicine. Because if your hormones are off, you can't recover. You can't recover.
Yeah. Stephen, I know that firsthand.
Yeah, and then if you're interested in any of the natural products that we have, it's at dhpusa.com, dhpusa.com. And, you're in Canada, getting stuff to you, you can send me an email how best to get it to you when you're in the United States.
Oh, I will do.
Okay.
Again, this was really, really great. Thank you so much for coming on.
Thanks for putting up with me. Okay.
It was a pleasure.
Okay. All right, Steve. And the two of you get together and, I'll send you some stuff. You just tell me where in the United States you're going to get it.
Okay.
Okay. All right. Take care.
Take care.
Bye.